Dr. Dad left out an important point, though. He brought in his secret weapon. He introduced me to his family right before we started, so I can't go too hard now. I'll feel bad. All right, we'll let everybody settle in. All right, I'm going to try and do this without a lot of fireworks. I said love and hate at the beginning, and people certainly love and hate the mode. I'm going to try and be a little bit more tempered and measured in what I say here. Obviously, I'm a pro APRV guy, but as I mentioned at the end of my previous talk, it's just a tool. You can absolutely hurt people with it, and so I don't want to mischaracterize the mode or my enthusiasm and say that it's great. You should leave here and immediately go back to your practice and just do it on everybody, because if you don't know what you're doing, you're going to cause some harm. So just scrolling through, let's see. Yeah, I'll have to just scroll through. So again, as I mentioned before, not all that glitters is gold. Lots of different ways to do APRV, some better, some worse. But when you lump such disparate ways to ventilate all into the same thing, it tends to muddy the conversation. I'm going to try and be a little bit more precise in how I speak about the mode in the next couple of minutes. But just, I wanted to give some examples. When you go through the literature, I just have two right here. There are more studies I could show you, but these were two studies, or two cases reported on APRV. I'll give you the summary of both of them, and it goes like this. We had a patient, they were super sick. I put them on APRV, then a bunch of bad stuff happened. APRV is terrible. If I was your fellow and I said, hey, I had this patient, they weren't doing well, they were on volume control, and I put them to SIMV, and then they died, we should never use SIMV again. Your next question would probably be, well, how did you set the mode? And if I said, well, they were on 30 ml per kilogram tidal volumes, and I took away the PEEP, you'd be like, I don't think you know what you're doing. You shouldn't be a doctor at all. But people put stuff like that in the literature with regards to APRV. They just turn off the way they think, as if it was APRV that was the fault and maybe not the way that they used it. So again, how do we use it? It's not the wand, it's the wizard. We're all familiar with ARDSNet, lung protective ventilation, PEEP FiO2 tables. Again, I would advocate for a way to use the mode called time control adaptive ventilation. Again, that's an entirely separate talk. I'm happy to answer questions about how we would do that. But there's a specific way that I think has been shown out in the literature through numerous animal studies, and certainly in my own practice, that I think shows benefit to using the mode. Sorry. All right, but yeah, you survey everybody, and a few of you have talked to me afterwards, and there's a lot of confusion about the mode. Well, I'd like to, but nobody knows what to do. And there are 3 surveys now in the literature where they've surveyed people on how they use APRV, and there's no consistent agreed upon way. And every single study that you'll read on APRV, there's always a qualifier of, well, there's no agreed upon consensus. I would just say we're in good company, because that's in like everything else we do in mechanical ventilation. What's our consensus on esophageal balloons? Paralysis, best PEEP. I think the way we should all do PEEP right now, it's not best PEEP or good enough PEEP. I think it's the I've given up on PEEP approach, and we just pick something and go. There's no consensus on numerous things that we do. Yet we don't have the same animosity about all these different things like we do with APRV. There's just this, quite honestly, a frank bigotry towards the mode. Again, I think people use it improperly, and that's how the mode gets such a bad rap sometimes. But there's lots of other things we don't have consensus on. But even if we did, that doesn't mean you're going to implement it right. If you're familiar with the Lung Safe study, huge international survey, even when we know we've got somebody with ARDS and we should be doing these lung protective settings, the vast majority of the time, we still don't do that. So even if we did have agreed upon settings, it doesn't mean you can just necessarily implement your standard mode. And I don't think that's the critique that, well, we don't know how to implement APRV. I don't think that holds true. I would tell you as well, APRV can be implemented. So back in the heyday of COVID, Phil Rolla, a friend of mine up in Montreal, we were having a phone conversation. I had just come back after volunteering for a week in New York City, where I took care of nothing but COVID patients. This was in the height of the surge. And he said, oh, you just came from the front lines. Tell me about your experience. I said, well, here's some interesting stuff about APRV. He had never used it, but had friends who had encouraged him to try it. So he and I kind of worked through the mode. He tried it, and sure enough, he became a believer in short order, and we published a case series. We then talked to some other colleagues and started what we call the TCAP course, and we've taught other people how to use this. So this is not robust data here. I don't have I don't have statistics to back up the number of people that took the course and what their effectiveness in implementing the study was. But lots of other people that we have taught since then have used it effectively, and have now joined us in our very lonely lives in our hospitals, where everybody else hates us for using APRV. All right. Can you still hear me? I feel like I lost the mic. You still? Great. So recent article just came out looking at the literature in APRV and was trying to make the case that you shouldn't be using APRV unless it's in the context of a randomized controlled trial. And in that article, they had this chart where they said, oh, look at all the different prospective randomized control trials on APRV. There's a trend towards significant harm if you use the mode. And I don't think anybody would ever look at that chart and thought that the word significant should have gone in front of the word harm. If you look at that plot, I put it green and red as the we should use APRV. And the vast majority of people are tilted in APRV, yet the authors put the word don't use it because it might be significant harm in front of APRV. So really, you should consider using it because there might be significant benefit. I think that's the appropriate reading of the literature. Now, for full disclosure, none of these studies that are being cited here are using a TCAV method. There are subtle differences, and this is where I think a lot of our 10-minute discussions about APRV go to pot, is there's a lot of nuance that you have to appreciate here. I'm very pro-nuance, if that hasn't come through in the 30 minutes I've been talking this morning. But if I wanted to be superficial, I could say thus far, all of our randomized prospective control trials in total support our use of APRV. Yeah, but if you go and look at those trials, we know it causes harm, right? So let's take a look at some of the weeds, some of those trials. This is the Hirschberg trial, came out in 2018. This was stopped early, common theme in our APRV trial, stopped early because there's harm. And that's not quite true. So in the study, they had 3 arms, a lung protective arm, an APRV arm, and then this kind of APRV hybrid arm where they try to manipulate the settings to achieve low tidal volume ventilation. Screened over 1,300 patients over 4 years, only ended up enrolling 42. And they ended up stopping the trial because the APRV arms had high tidal volumes. So it causes harm. This little figure from the study is really what caught everybody's attention. Just to kind of orient you, the yellow outline here, this is the distribution of tidal volumes for the low tidal volume arm, and you can see that they were consistently 7 or below. Your green is that APRV hybrid arm. I just want to point out, it doesn't cross the x-axis at 20 mLs per kilogram. Some of the patients in that arm were getting over 20 mLs per kilogram. I'm not advocating for that. Please don't leave here thinking that I thought that was the case, that was okay. And then in your APRV arm, they had patients with 8, 10, and 10 milliliters per kilogram tidal volume over days 1, 3, and 5. So they stopped the trial early because there's all these high tidal volumes. We all know you can't have high tidal volumes in ARDS, right? Like that's against standard of care. Trial is stopped. Except when you went back and look at the APRV arm, it did better. Right, so we conflated the low tidal volumes with benefit, when really even with higher tidal volumes, the APRV arm had benefit. I don't think you have an appropriate framework for how to interpret this study. I think I do, and I'm happy to talk to you afterwards about why that is. But I just want to say, be careful when you interpret APRV studies, bringing your assumptions to the conclusions of those trials. Interestingly, I spoke with Hirschberg after this trial came out, and she said the animosity towards APRV was just incredible. They had a lot of problems with protocol adherence, as you can see in those giant tidal volumes in the APRV hybrid arm. But the reason why the trial was really stopped early was not because of harm, but because it was difficulty with recruitment. Again, there's a lot of animosity to the mode. They'd spent 5 years. They had only 52 patients to show for it, and I think she was just done with the trial, quite frankly. All right, the one trial, this is kind of the elephant in the room for APRV, is the ZOO trial. This came out in 2017 from China. This is our largest randomized prospective control trial on APRV, 138 patients who had been ventilated for less than 48 hours and had ARDS, put in an APRV arm and a lung protective arm. And in pretty much every metric you can measure, vent days, vent-free days, ICU stay, ICU mortality, APRV was significantly or almost significantly better. I mean, look at that, 0.053. If one more patient in the APRV arm had lived or one more patient in the control arm had died, this would have been a greater than 10% positive mortality reduction for APRV. So when this came out, a lot of discussion, lots of debate, and I'll summarize all the debate by basically saying the critique of the trial is not that APRV did so well, it's that the control arm did so poorly. I had a link I was going to show here. If you want, there's lots of papers. I think the best review of the trial, though, is actually a particular podcast It's the Critical Care Practitioner podcast, number 129. So if you want to jot that down in your notes, you should go back and listen to it afterwards. But I think they did a nice takedown of the study, quite frankly. And I think that critique is true, that the control arm was pretty poorly managed in the study. However, if you go back and look at the control arm from ZOO, sorry, this is where the PowerPoint would be better than the PDF, and you compare it to the FACT trial, I think that critique holds up. If you add in the Express trial, I think that holds up. Our low tidal volume arm has a worse mortality than these other two kind of benchmark randomized prospective trials in mechanical ventilation. And same thing with the LOVES trial, right? So FACT, Express, LOVE, 3 major mechanical ventilation trials, all 3 significantly different and better outcomes than what the control arm was with APRV. So not the best comparator in this study. However, when you look at the ZOO APRV arm, it still does a lot better than these other trials. Tons of methodological issues with what I've just done. This is not how you do statistics. I want to make that clear for any statisticians in the room or whoever's watching online. But if you're going to say that the control arm was poor, we shouldn't consider this valid, then you have to deal with, and you're going to use that as a valid means of evaluating the study. I think you at the same time have to say, well, the APRV arm did extremely well. All right, every one of these could be an entire talk unto itself. We have a lot of things that we know improve mortality in ARDS. And with APRV, if you go through almost all of them, I will tell you that APRV improves those specific areas. So lung protective ventilation. I will tell you that APRV, when done with the TCAV method, usually results in initially lower tidal volumes. We were talking about lung rest, lung protective ventilation with ECMO earlier. I like APRV on ECMO because if you control that T-low appropriately, you get very stable resting alveoli. Your driving pressure is typically 1/2 to 1/3 of the P high. I've never switched somebody over to APRV and had their driving pressure been increased. The few studies that have looked at driving pressure on APRV have decreased driving pressures. Dead space and the ventilatory ratio are improved. I talked about that some earlier. Desynchrony, there's none, assuming a couple things. Once your T high gets too short, you can have some discomfort with the mode, but it's an asynchronous mode. There's nothing to be desynchronous with because you're not synchronizing anything. It's just CPAP. I tell my fellows it's CPAP with a bunch of hiccups. But if you're having a hiccup every 2 seconds, then it's uncomfortable. Respiratory rate and its contribution here, who knows? But if you've got improved dead space and ventilatory ratios and ventilation, stands to reason you'd have a decreased respiratory rate. Mechanical power, this comes up all the time. Oh, you're spending all this time at that high pressure. You've got to have really high mechanical power. Remember, that's just a static. Your P high is just static. The dynamic portion is usually less, and the few studies we have on mechanical power and APRV show slightly less mechanical power on it. There's lots of problems with those studies. And lastly, your P silly, that's a whole other talk in of itself. I think you can monitor this a lot better with APRV. In fact, one of the things that really attracted me to APRV when I first learned about it was I was trying to take care of a patient who was on the mode. I had all these questions. My consultant said, well, have you looked at the patient? Have you examined the patient? And I thought, oh, I hadn't. And I just realized how much time I'd spent looking at the ventilator screen and how little time I'd spent looking at the patient. I think APRV allows you to examine the patient better. I think you're more attuned to how they're breathing. And again, assuming a couple things about sedation, I think they can wake up and participate and let you know how they're breathing better than other modes. Lastly, anecdote. This is not data. I want to make that very clear. So this is not what I'm going to hang my hat on. Another reason I really got into the APRV, went down the rabbit hole, when I volunteered for that week in New York City, I was in charge of 18 intubated COVID patients, all on death's door. Of those 18, 13 of them died, 3 were trached, and 2 were extubated. The only 2 that were extubated were the 2 that got put on APRV initially. And that's what made me tell my friend Phil Rolla, there's something here. And he started playing around with APRV and has now become a believer too. This is a picture I took from one of the patients I took care of. I'd made some adjustments to the ventilator. A few minutes later, the nurse flagged me back, said something's not right. He was kind of freaking out. And I handed him some paper and he wrote scared. And without telling him anything that I was doing, I was just having a simple conversation. I reach over and I'd adjust the ventilator. And 2 minutes later, he wrote, the air is good now. He had no clue what I did on the ventilator. I didn't tell him I was doing anything. I just kind of made some adjustments. The adjustments I made were to put him back onto his settings before I changed them, and he kind of decompensated. And his settings at that time were a P high of 34, a T high of 4 seconds, and a T low of 0.25 seconds, and a P low of zero sedation. This guy had multiple pressors. He'd been in the ICU for a week. But again, this guy was comfortable enough that I could have a conversation and he could write all this despite a P high of 34, any less, and he freaked out, right? Or he wrote scared. So again, not robust data. It's not a study that I'm going to have, critiqued in the literature, but it's a powerful anecdote that I can't leave me. And then lastly, just to emphasize the point again, APRV is not a 4-letter word. It's just a tool, and it is all how you use the tool. And with that, I'll have these up.
All right, thank you, Ben. So now time for the villain. Here's the problem, and I'm just gonna open. I'm actually a pro APRV guy, and I will show you. Just 1 second to get the presentation. We need to have somebody speak bad about it. So it fell to me. I didn't want to be like. So if you hate APRV, you would like me right now. If you don't, if you like it, you will hate me. But well, it is what it is. So we're going to talk about the cons. And here's, as I told you, I actually published like good 9-10 articles about APRV, and some of them are studies glorifying APRV. But now I have to talk bad about it. Matter of fact, that study in respiratory care from 12 years ago, it's like the most cited study in APRV, with 300 citations and stuff. So those are the studies. Those are another studies. Actually, Dr. Sato here, we did 2 studies. And then there's a couple in our journal about surveys, maybe we'll talk about it, and even prone and APRV in COVID patients. More studies and more posters and when we're in Cleveland. So I'm going to start by mortality. You heard about, does APRV improve mortality? And I can tell you that, I think if you use any mode, if you use it good, yeah, you might help improve mortality. If like the slide that he showed about the shaving, if you use it bad, you're going to kill the patient. So, so I can't say that there is not even a single study saying that a single mode is just by putting the patient on this mode, you're going to make him survive. And if you deprive them from that mode, you'll make him die. So no. But what do we do right now? So this is a study. Again, most of the studies are small patients, like 25 patients. But if you can look at this highlighted one, there was no improved mortality, and maybe even people who had were on APRV had some problems. Another one from trauma, showing the same patients when APRV had increased ventilator days and more pneumonia, but they were sicker and stuff. I'm not going to go through everyone. This is in neonatal or pediatric patients, a little bit, maybe 60 patients or something like that. And again, ventilatory strategies, APRV, they had worse trend towards worse mortality. Okay, so why is the mortality like we don't know? The reason is the problem with the studies. Okay, so the studies are very heterogeneous, different patient population, just like even if they're all ARDS, we know now that ARDS are not the same. Early ARDS versus late ARDS are different. ARDS has pulmonary versus extrapulmonary causes. Now we have different phenotypes. So you can't just say by just you are an ARDS, it means that they are the same. So the studies are different. As you heard before, everybody has his own settings of APRV. Some use very high T high, some don't. Some put P lows 0, some people have no P low. So this is one of the problems. Methodological limitations. Again, some of them are old, observational, small studies. There's definitely a risk of bias. Some meta-analysis even showing, yeah, there might be a trend towards improved mortality. Then the next, year, another meta-analysis, no, there's no mortality difference. Patient-specific factors. Again, We don't have good studies to say what's the optimal ventilation strategy to use in APRV. And we mostly concentrate on mortality. So is mortality the only thing that's important? I don't know. But anyway, so it has a lot of problems. Now, ambiguity. If you use, I'm sure you all use different ventilators. Here's the problem. If you even dial the same APRV in this ventilator is different from APRV in this ventilator. So we have like 6, 7 ventilators. Doesn't mean that you put APRV with the same setting. It means that you're getting the same results. So you have different names. You have APRV, you have TCAV, BiPAP, bilevel, duoPAP, biphasic, you name it. I mean, if somebody, you should have called it Dr. Downs, instead of like APRV. That would be better. There's only one Dr. Downs. So that's a problem. Now, when you heard Ben talking about the plateau pressure and the driving pressure in APRV. So I'm going to question a little bit, what is the plateau pressure in APRV? What's really the tidal pressure or the driving pressure? What is the PEEP? We always set P low of 0, and we think the patient probably has some auto PEEP, but how much auto PEEP? Which is supposedly we use it instead of PEEP. What honestly more important for me is now that we use a lot of esophageal balloons, especially in the sicker patients, how much is the long seeing of that pressure of APRV? So we're going to talk about transpulmonary pressure and the mechanical power. And you mentioned a little bit about mechanical power to talk about. Here's the problem. So when we use APRV, we use very short T-low, whatever you do, it's 0.2, 0.3, 0.4. The idea is to create auto peak. So we're less than the time constant of the lung on the expiratory flow here when it empties. So ideally we're supposed to be using some auto peak. Here's the problem. So this is from a study we did before on a simulator. We know the compliance, we know the resistance, so we know the time constant, which is on the left. So we expected time constant is in that left. So you can predict the auto PEEP. In reality, when we put the patients on the ventilator, the measured auto PEEP and the measured time constant were totally different from what you're calculating. So that's a problem saying, this is another study we did on 4 different ventilators. This was years ago. And you can see on the left side in the black here, that's what's expected time constant and expected time constant, expected auto PEEP on the right side. Each ventilator had those same settings, same compliance, same resistance, same mechanics, with same settings. Each ventilator is giving you different numbers. So that's a problem too. All right. So this, we also published this study a couple of years ago. Basically, we used how to set the T-low. For me, the most important setting on APRV is the T-low, because that's what you're creating, the auto PEEP, and you're supposed to prevent the collapse of the lung. So how do we set it? We usually set it empirically. You look, some people are like, oh, between 0.2 and 0.7. Well, that's a big difference, especially in very stiff lung that wants to collapse. And I'm gonna talk a little bit about the TCAV, how I don't like it, just the way it is done. But anyway, so this is a study where we basically put on the top is the airway pressure, second one is esophageal pressure, and we're measuring the transpulmonary pressure with different, and the flow down from 0.1 seconds, 0.2, 0.3. So if you look at the transpulmonary pressure, the third one, you would think that, oh my gosh, you're like -10 during exhalation, during the release. That's not good. The question is that true or not? Probably not true. So this is the same study. So what we did is we want to know how much really auto PEEP are we creating during APRV with different settings, with different T-lows. And, we're doing the end expiratory transpulmonary pressure. So like any ventilator here, if you can see the arrow here, you can see it. On the top right, or that orange arrow. So we put an expiratory pause and you get the auto PEEP. So with this, whatever time T-low here of 0.3 seconds, we know that our auto PEEP is 21 centimeter of water. And with that, the bottom arrow, like the end expiratory transpulmonary pressure here, I think it's like 6. So despite that's 0.3 seconds, and I don't know what's the flow decay is, probably more than 70% of the TCAV, right? In TCAV, they want you to do it 75%. This is less than 75%. And you still have an end expiratory transpulmonary pressure is above 0, which is usually like to prevent collapse. Again, so what is the driving pressure? we talk about the driving pressure in APRV is whatever. We set it here at 30, the P high is 30. The reality is no, because we have a P high of 30, but we, as I told you before, we have inspiratory pause of 21. So the real driving pressure is about 9, which is good, okay, because people get scared, especially if we go up to 40 or 50. You know, it's like, oh my gosh, this is like so bad. You have to keep the plateau below 30. You have to keep the driving pressure, blah, blah. So the reality is it's actually the driving pressure is less than that. And if you look at, more importantly for me, nowadays I don't try not to look at the airway pressure because it's, again, chest wall and lung. I want to know what happens inside the lung with somebody who's, how much the lung is seeing the pressure or the stress. So that's why with oxygen balloon, now I'm getting a transpulmonary pressure very low, actually, from like maybe 15 down to like -6, like about 9. So that's pretty good. Anyway, I'm not going to dwell on this too much more. How about TCAV? So I actually asked that to Dr. Neiman, Gary Neiman, who's a very smart guy. Why the heck did you pick 75%? Like, why? Why not 70? Why not 80? Why not 65? And of course, he didn't have an answer. The idea is the shortest, the better. But that is actually might not be true, because if you're creating too much auto-PEEP, you might be hurting the interthoracic pressure in the right ventricle, causing ventilator-induced lung injury, blah, blah, blah. So what happens when people who have very high resistance? You know, of course, if you have very high resistance, you're going to have more auto-PEEP and a problem. So that's why you shouldn't probably use it in people who have high resistance in general. What is the auto-PEEP? We already talked about this. Again, you have to know what's your compliance, your respiratory mechanics, to decide that not every lung needs 75%. All right, mechanical power, you mentioned it. This is a simulator one, we did it. So it's easy to calculate the mechanical power in somebody who's static, because you know that's area under the pressure volume curve and stuff. We'll talk about this tomorrow. Problem is, now you add some spontaneous breath, like here, that red one. Sorry, I made this with a simulator. So you see the volume and whatever. What is this mechanical power with the patient? Now the patient has a PMUS power, his own inspiratory, and the ventilator power. So if you look at the green, the table that on the right, there's ventilator work, there's patient work, there's total work. Now, is the patient, when he's spontaneously breathe on APRV, does that worsen the mechanical power? Probably, because as any pressure control mode, and again, we'll talk about this tomorrow, you're adding to the mechanical power. Okay, how about clinicians, sorry. How do we set APRV? So this is from our journal a couple of years ago. We give people options, all clinicians, maybe 200 from all over the world. We give them 5 options for each setting. And you can see, no consensus, everybody use whatever he wants. So again, the APRV that you would use in your hospital might be different from the one that I would use. We talked about this a little bit, that it's different. Some ventilators actually, like this is the 840. If you can set the T low at 0.4 seconds, but look at this left one. It is 0.4 seconds because the patient didn't breathe immediately before it. Then the next breath, that T low is actually much longer than. Why? Because the ventilator, the engineers put something called synchronization. So sometimes that T low can go up to like 1 second. And now what's your auto PEEP there, or what's your PEEP? Probably went down to 0 and you're worsening probably long collapse. Okay, spontaneous breathing. Again, we talked about it a little bit. I don't want to spend too much time, so we can have the real debate. Now, I think the way to really set APRV is with EIT, and there's some studies start to come up, you know, now with EIT, with APRV. I found only 2 studies. Here, there's this one showing improved in the dorsal ventilation. Anyway, so in conclusion, so this was from 2018, so it might be a little bit old, the study. While APRV has theoretical advantage and some studies suggest mortality benefit in ARDS, it's crucial to acknowledge that studies have not found such benefit. In some cases, some potentially worse outcome. Need for careful patient selection, meticulous application of the mode, and large quality studies. What I would tell you anecdotally, I used it and I thought people would die if I didn't put on APRV, especially with proning and stuff, but I can't tell you like APRV saved them, I don't know. My point is personalized ventilation. doesn't mean that you're bad oxygen, just throw you in APRV, and some hospitals have protocols and you just have to follow it. So, no, you have to know more about it. All right, with that, let's see who wins that debate. I do. Please, any questions or anything that that's great. We're still friends.
Frenemies.
Thanks for that great debate. Dr. Daxon, you keep mentioning caveat of, well, you can't use it wrong. What are the most common ways you see it used wrong? What are the times you definitely avoid it? And then my second question, if you won't mind me asking two questions, it simply does not work on some ventilators. Certain valves aren't placed to make it work. Do either of you know off the top of your head, like, hey, if your hospital uses this brand of ventilator, this type of ventilator, don't try doing this?
We'll take them in turn. So the most common mistakes I think I would see, there's the mistakes I see in practice and then the mistakes I see in the trials. A couple of the mistakes in those trials, one, they let the T-low go out to 50%. And that may sound trivial, but I would tell you letting the T-low go from 75 to 50% is doubling it. It's no different than letting the tidal volume go from 6 mLs to 12 mLs per kilogram, right? We don't think of it in those terms, but if 6 mLs per kilogram is like the inviolable rule of lung protective ventilation, then the 75% cutoff would be the inviolable rule of APRV, at least according to the TCAV strategy. So that would be one. Two is, I think spontaneous breathing is another issue. You can't get, people try and have a unnecessarily long T high. They want to, so I spoke this morning about trying to recruit and you have that long time at the T high. And so there's an old paper by Dr. Bashi in 2005. He said you want to aim for a starting point of 10-to-1 on that I to E ratio. And so people try and keep that nowadays, but sometimes the lung just won't let you have that long of a T high. Sometimes you have to have a shorter T high in order to bulk ventilate as much. But if you don't do that, then you have to let the patient do a bunch of spontaneous breathing. And if you have a patient with a PF ratio of 60 and you just let them breathe willy-nilly and you're not supporting them in any way, or you're supporting them minimally, I think you run a lot of risk for P silly. The last thing I would say is, this happened a few weeks ago in 70E. Dr. Barrero's, he's my fellow, this is his last day of fellowship. He came from Mayo. So this was not a planted question, I just so you know. We actually had this issue a few weeks ago in my surgical ICU. I'm the unit director. We had a patient put on APRV, did beautifully over 24, 36 hours. And then over the night, nurse had a question, something wasn't quite right. I still don't understand the details. And the APP went over and said, well, I'm a little concerned. I don't know what's going on. I'm just going to sedate and paralyze the patient and they can figure it out in the morning. So it took off half of the patient's minute ventilation instantly because now the patient wasn't breathing spontaneously, made no other changes to the ventilator. And the RT came back in a tizzy an hour later because the PaCO2 was over 100 and what's going on, and all hell broke loose after that. So just people not thinking about the mode and that they have to make adjustments, I think is another common problem. If you have other things you see commonly.
Yeah, no, I think I'm going to answer the question of what ventilators or whatever. So you see that study that I mentioned, like we compared 4 ventilators and they showed different. Of course, we didn't see, like you can actually, we have in the study, you can take a look at it. Some ventilators did better than to the expected than ones. None of the new ones, like I don't use any of those 4 ventilators, we use the fancy schmancy ones nowadays. But there's no studies basically to say, oh, use this ventilator is better than this one.
The old servos I know are notorious for kicking out the T-low. I don't think the newer Hamiltons don't do that. The new Dragers don't. I don't know who else. I don't know what other reps we have here, so I don't want to speak, speak too much.
The Bella Vista. Yeah. They all do okay.
I have a question. So how do you assess effective pulmonary perfusion during this? What are you? I hear everything about mechanical ventilation in the lung and power and blah, blah, blah. But I rarely hear anything about the impact on preload
Yeah.
or effective cardiac output.
That's a great
Effective,
question. I will go on and then I'll let
You
you.
get a point on that.
That's a great point, actually. So APRV, if you look at our review back, I told you it's like 2012 in the American Association of Respiratory Care. It actually, one of the benefits of APRV that the patient's own spontaneous breathing, it improves the venous return and thus improves the cardiac output and hemodynamics. Saying that, and most of the study actually in animal studies too, consistently APRV improves hemodynamics and perfusion and stuff. Now the problem is we don't measure it, right? We only measure blood pressure in our patients, which is another big topic of like patients in shock and whatever, and all what we're measuring, oh, we want to keep the mean at 65, which is wrong. We need to measure cardiac output. We now have new ways of, I know you're going to talk about this tomorrow, measuring perfusion and oxygen delivery and oxygen consumption, stuff like that. But that's like, again, with any other mode, like it's our fault that as clinicians that we don't measure all this mechanism.
Yeah, crudely, it's just the blood pressure. I mean, that's a terrible way to think about it, but that's probably practically what I think most people do, unless you have a bunch of invasive monitors, which then you can start looking at those things specifically. The one thing I would say about the blood pressure and hemodynamics, that always comes up. So in any of these debates, it's always like, aha, I got you. You're going to give all this pressure and you're going to crush the right heart and hemodynamics will be screwed. Again, if the right heart does best when the lung is at FRC, and if you can recruit the lung back to FRC, the right heart, you're going to win out that hemodynamic debate. That's not an APRV thing, though. That's at every ventilator mode. Everybody would love to get their patients back to FRC. Yeah, the question, how do you do it? How do you get them back to FRC? And so I told you is with APRV, it's time that you use to recruit, not a bunch of blasts of pressure. What I would say is that if you can be patient, you'll get there. Again, excluding, I know, fibroproliferative, sometimes the lung is a big scar. It's not going to happen. But in general, it usually does, and especially in patients that you wouldn't think it would. The other thing is sometimes when you initially put patients over, the lung recruits gradually, but it overdistends instantly. And so when you initially put people on APRV, you may have a little bit of some rapids in the river for your first hour or two. I would say if you can be patient and get through that, it'll be worth the cost of that first hour or two will be worth the payoff in a day or two. And I liken it to putting patients on CRRT. We've all started CRRT on a patient, and maybe you have to go up by 0.02, 0.03, 0.04 on your NORAPI, right? Because you're struggling pulling out some of the preload, like, what do we do now? Most everybody at this point says, look, I know it's a short-term cost, but this patient needs fluid off. It'll be worth the gain once we can get them run on HD or CRT. And I think that same principle applies to APRV. If in all the APRV studies we have, for all the theoretical harms of hemodynamics, all the studies show benefit hemodynamically with APRV.
Thank you. Oh,
I think we've got,
yes, sir. Oh,
I think
okay.
we have to take his question.
Just tell us the answer. Awesome.
Really encouraged. Is this on?
You're on,
I'm
yeah.
really encouraged to hear comments that are aimed at physiology about pulmonary resistance at FRC being minimized and so on. We had an argument with Warren Zapel back in 1974. If we went to higher levels of peak, we would increase pulmonary vascular resistance. But we had catheters in everybody, and pulmonary vascular resistance went down as we titrated to peak to higher levels. An observation that I still am not sure is in the literature, that obviously you know that, and you've seen it, as many of us have. The other thing is that you mentioned the lower dead space with APRV. It's the alveolar dead space that's lower, that part of the physiological dead space. And so we started using end-tidal CO2 more as a measure of pulmonary circulation. I wonder if that's becoming more common or not to look at gradient in end-tidal and arterial CO2, minimizing that, which APRV does.
So I look at that gradient. So if I ever put somebody on APRV, I know I'm going to get hammered with 1,000 questions. So I put on volumetric capnometry, I put esophageal balloon, I put in everything, not because I need it, but just to show all the values. And certainly you see the end tidal PaCO2 gradient decrease as you recruit over time, and you get better VQ matching and decreased dead space. So yeah, that's been my experience. And your point about decreasing pulmonary vascular resistance with increasing P. We have a study from one of our fellows 2 or 3 years ago at Mayo showing they looked at right heart function. You take it as a surrogate for pulmonary vascular resistance. And what we showed was a U-shaped curve of right heart function with P. So I think typically people think, oh, if you go up on PEEP, you're going to make the right heart worse. That's not true. It's a U-shaped curve. And the better your PEEP gets you to FRC, the better your right heart will do, presumably because you've got decreased pulmonary vascular resistance because you've recruited.
Yeah, well, this is a theoretical question.
Yeah.
So with the advent and improvement in technology of non-invasive cardiac output monitoring, where do you see that going with research on APRV and monitoring benefits?
Yeah, I mean, now we're moving towards more non-invasive, especially with EIT now, that it's probably going to see more and more of it. It doesn't only measure ventilation. Now it measures cardiac output and perfusion. So breath by breath, you're not only seeing the air coming in and out, you're seeing the perfusion, and you can actually see the ventilation perfusion ratio, breath to breath. You can measure the cardiac output and stuff like that. So I think our monitoring is improving. Maybe we don't pay close attention to it all the time, or we don't have it, or, I think it will get better over the next, we'll know more. As you heard, APRV has been there for 40 years. We still don't know much about it. We're standing debating, is it good or bad, or how to reset it? And, you would think we should have known by now. You know what I mean? So hopefully, I think in the next 100 years, people would look at us and it's like, oh my God, those were monkeys. Were you really practicing medicine like this? 100 years shoving tubes and stuff. So things will be better, but I don't know when. We'll get it. So, yeah.
Yeah, I'm all for non-invasive monitoring. Irrelevant though, unless you're actually using APRV. I just have to convince more people to use it in the first place. So,
All right. Thank you, everybody. Thank you. Okay. So the next thing is the